Welcome. Thank you for joining this presentation on barriers to early HIV detection and recommendations for improvement. This is a summary of a qualitative study of individuals concurrently diagnosed with HIV and AIDS in New York State. My name is Sonia Peck. I'm an evaluation specialist at the New York State Department of Health at the AIDS Institute. I want to start with the definition of concurrent HIV and AIDS diagnosis. For this study, we defined concurrent diagnosis as occurring when a person is simultaneously diagnosed with both HIV and AIDS or receives a AIDS diagnosis within 30 days of receiving their HIV diagnosis. Data shows that a late-stage HIV diagnosis results in increased community spread by transmitting the virus to others unknowingly, increased medical costs, experiencing poor quality of life, and increases in mortality rates for those newly diagnosed. In 2014, New York State declared a 3-point plan to end the AIDS epidemic in the state. The plan outlined efforts to identify persons with HIV who remained undiagnosed and link them to healthcare, retain persons in healthcare to maximize virus suppression and to prevent further transmission, and third, to facilitate access to PrEP or pre-exposure prophylaxis for high-risk persons to keep them HIV negative. New York has adopted several policy changes aimed at facilitating earlier identification of HIV infection, such as requiring HIV testing as part of routine healthcare, the removal for the need to have written or oral patient consent for testing, and then also expansion of minors to be able to consent to HIV treatment and preventive services without parental involvement. With these efforts, New York State's newly diagnosed HIV cases have declined from 3,443 in 2014 to just over 1,900 in 2020. However, our concurrent HIV and AIDS diagnosis rate have hovered between 19 to 21% in that same time period. These percentages exceed the state's ending the epidemic target of 15% and highlights the disparity in cases, as persons of color accounted for 80% of all concurrently diagnosed cases. To understand how else the state could intervene to identify HIV cases sooner, we designed a qualitative research study where we interviewed patients concurrently diagnosed with HIV and AIDS to understand barriers to testing and late HIV diagnosis. So we use data from our state HIV surveillance registry and the AIDS Institute reporting system to be able to identify persons served by AIDS Institute funded providers who were concurrently diagnosed with HIV and AIDS, and to ensure that these participants were exposed to the 2014 New York State AIDS Institute initiatives. We restricted the sampling framework to individuals who resided in New York State at least 3 years prior to their diagnosis. And we also restricted the time frame for being diagnosed to occur between January 2018 and June 2020. Finally, due in part to resource constraints and the COVID-19 pandemic, we further restricted our sample to participants who lived in Western New York region. So we were able to interview 9 individuals starting in December 2020. There were 8 males, 1 female, ranging in age from 24 to 58 years old. 4 participants identified their race as white, 3 as Black, and 2 individuals identified as Hispanics. Findings from these interviews revealed a combination of contributing factors that led to a late diagnosis among these individuals interviewed. One, while all the participants in the study had access to health insurance, at the time of their illness, some had declined coverage from their employer due to a lack of affordability or a high premium. Those with health insurance avoided using it because of the associated costs, again, such as the copays or the loss of pay from having to miss work. Others explained that they had avoided preventive care because they were uncomfortable interacting with the medical community. They associated doctor's visits with bad news, or some also stated that they had no childhood history of seeking healthcare, and so that wasn't a practice that they carried over into their adulthood. And then others reported that they didn't visit the doctor because they never felt ill. So all the participants indicated that they had never discussed sexual health with their provider. This includes those with a history of healthcare use and those who presented to facilities while exhibiting symptoms of the HIV illness. One participant reported only discussing sexual health in the context of the human papillomavirus vaccine, which is given during adolescence. Some participants who knew that they were at an increased risk avoided testing for the fear of learning the results. They were mostly concerned for how their family and friends would respond, or some also reported feeling ashamed for allowing themselves to be associated with the virus. Interestingly, none of the 9 participants knew any signs or symptoms of HIV, which might not be so uncommon. While most participants knew some of the risk of acquiring the virus, they were unsure of how the virus presents itself. When asked about signs, they often described late-stage HIV, such as rapid weight loss, weakness, and trouble eating or swallowing. And then finally, most participants in the study had presented at different healthcare settings at least 1 year prior to being diagnosed. Oftentimes, they were tested and treated for other health conditions, all the while their HIV worsened. So one participant reported receiving an abnormal test result, but was told by the provider that it was not something to worry about. And at least 2 discussed having surgical procedures without an HIV test prior to those surgeries. Some of these barriers experienced by individuals in the study are not unique to this group. Even though the nature of the study design itself does not allow for generalizability, the results themselves align with other findings presented in previous literature. So the first 3 barriers outlined can be reduced by ensuring that HIV testing is incorporated in all medical visits, especially before any surgical procedure. This strategy has been mandated for all birthing experiences in New York State and has worked to capture birthing persons who lacked routine perinatal care, routine prenatal care. It's also offered the opportunity for early intervention for newborns and has also worked to reduce stigma of being asked to conduct the test during labor. Another recommended strategy that emerged from this study is the need for refreshed education around the risk, signs and symptoms, and current treatment options for HIV. Participants in the study did not have sexual health conversations with their healthcare provider, and only one participant remember learning about the risk of HIV during their high school years. Additionally, many participants in the study reported that had they known about the current treatment options available, they would have tested sooner. When commercials for HIV treatments were referenced to these participants, they often reported that they didn't notice those commercials until after they were diagnosed. One participant also voiced the concern that our own social media campaign might be contributing to the promotion of stigma and shame among the LGBT and gender non-conforming community and communities of color by showing a larger proportion of these groups in HIV social media campaigns. As such, the one recommendation was to ensure representation from all groups, which could show those who may not consider themselves or who others may not perceive to be at risk, to be more aware. And these may include people such as CEOs of organizations or even medical providers and more heterosexual couples. These findings indicate that a variety of individual and system level factors may be involved in persons being diagnosed many years after acquiring the virus. The implementation of public health policy is necessary to reduce our current concurrent diagnoses trend. Recommended policies, however, must build on existing policies to increase access to HIV-related education, testing and treatment, and they must also align with the ETE priorities or the ending the epidemic priorities that I mentioned earlier. So one particular policy would be to integrate HIV testing consistently in all primary care and emergency room visits per the existing public health statute in New York. So this was recommended to increase earlier diagnosis and to decrease the stigma associated with HIV testing. Currently, the state requires that HIV testing be offered to persons 13 years of age and older in a healthcare setting. However, our data indicate that this is not happening. In fact, extensive New York State evaluation has shown that less than 3% of persons visiting emergency departments are tested for HIV. It may be possible to increase HIV testing in healthcare setting through targeted education to healthcare providers, such as through written communication, and also through continuing education training for providers. And also by adding an enforcement component to the requirement, similar to those used to ensure the prenatal HIV testing occurs during the labor process. We may also want to promote the use of home testing or self-testing kits, especially among those who may feel uncomfortable talking to their medical provider about their sexual behavior, as was highlighted by barrier number 2 in the study. And this may help also to reduce stigma. Another policy recommendation is to promote age-appropriate sexual health education in all primary care settings to address the topic of HIV and not just HIV, but other STI prevention in a positive manner. This includes education and access to all prevention interventions, including PrEP. Here, we may want to consider integrating a peer navigator component to promote engagement and acceptance of education and testing and treatment among the patients. Of course, the recommended policies that I just mentioned must be instituted with a health equity framework that prioritizes integration of trauma-informed care and cultural awareness to promote individual engagement and trust. So in summary, this study occurred during the early stages of the COVID-19 pandemic, which contributed to a reduced sample size of available participants willing to be interviewed during the time when New York was advised to shelter in place. However, the study offers critical insight in understanding hard-to-reach patients who present to healthcare facilities during the later stages of their HIV infection. A key strength of this study is the ability to hear directly from concurrently diagnosed individuals. These 9 participants provided important insight into their healthcare use, their knowledge of HIV and AIDS, and their perceptions of risk for HIV and AIDS prior to being diagnosed. They also shared 3 important recommendations that I've reviewed a few minutes ago for increasing opportunities for early HIV detection. One being mandatory testing for HIV, specifically before all surgical treatments, increase in education around the risk, signs and symptoms, and current treatments for HIV, and improvements in how people with HIV and AIDS are represented in the media. Finally, despite our small sample size, a lot of individuals and organizations contributed to this project. And so I want to acknowledge members of the Concurrent Diagnosis Research Team who contributed in various ways to the study, especially Katarina Colon, Shu-Yin Leon, Dr. James Tesoriero, and Jason Pendergast. Additionally, special thanks goes out to the nine individuals who took the time to speak with us about their experience being diagnosed and living with AIDS. Also, the AIDS Institute funded medical providers who assisted with recruiting and building trust between the interviewer and the participants, which was of tremendous help in getting those participants to speak with us. And finally, to the New York State AIDS Institute leadership. Thank you so much for listening.